Hello, welcome to this video where we are talking about hyperkalemia. In this video, we're going to talk about some of the people who might be experiencing this, the ways that they might present, and a little behind the why it's happening. All right. So let's start with who is experiencing hyperkalemia. Number one patient you're probably going to think of or see is going to be your patient who missed dialysis, as well as the diabetic ketoacidosis patient, those experiencing crush injuries, burns, and rhabdo. Now, this list is not exclusive. There are several other things that could cause it, but these are some of the likely culprits that we may see in EMS. These patients are going to present, again, with a host of symptoms, but these are the hits, all right? Weakness, fatigue, altered level of consciousness, bradycardia, hypotension, and ECG abnormalities, which we will get to shortly. But before we get to those, I want to lay some groundwork and foundation for understanding how hyperkalemia is detrimental for our patients, all right? And I'm going to do that by talking about membrane potential, all right? Now, I don't know if you guys have gone through anatomy and physiology classes before, but this is something that it's kind of easy for our eyes to glaze over because it can be kind of intense. So I'm going to do my best to kind of come at it from a simple way to understand it. This is something that you can dive into as deep as you want, all right? And I want to look at it just under the lens of hyperkalemia and how that jacks up membrane potential and has potentially disastrous effects for our patients, all right? So here I have a crude rendering of a cardiac cell here. And you'll notice that there is a lot of potassium, annotated by this K, on the inside of that cell, all right? On the outside, you'll see a little bit of potassium, as well as some sodium ions, annotated by Na, on the outside, all right? Relatively speaking, there is a positive charge on the outside and a negative charge on the inside. And this difference in charges creates a kind of a battery-like effect, all right, that we call membrane potential, all right? Now, once this cell receives an electric stimulus, we'll say from the SA node, it will open up a channel. And that channel is going to allow these sodiums over here to rush into the cell, all right? And so now the inside of that cell is going to have potassium ions and sodium ions. And what that is going to do, once that sodium comes inside, that cell is going to do its job or depolarize, all right? So in the instance of a cardiac cell, it's going to say, contract and send that message to your friends around you to contract as well. We have a job to do as cardiac muscle cells, and it's vital. And so that's how contraction and depolarization kind of works. All right. Now, this changes membrane potential by all those sodium ions entering, all right? And so it's going to take some time for those things to reset and that membrane potential to come back to its baseline of about 90 millivolts, all right? But once that happens, you're going to have this door shut here. One will open up, and then we're going to have these sodium ions that were in here exit, and things are going to start to restore to their normal baseline, and the process can repeat. And this happens very, very quickly, and that's under normal circumstances, all right? But when we have a patient experiencing hyperkalemia, we have an excess of potassium ions hanging out around the cell, and that changes membrane potential because those charges are relatively different now, all right? And so, yeah, the cell may get that electrical stimulus from the SA node, and the door will open up, and sodium will come right in, But due to that change in membrane potential, it's going to have a really hard time getting back to that baseline level of charge for the sodium to then exit the cell and the process to be perpetually done, all right? And so it kind of, for lack of a better term, that sodium kind of gets gummed up. His shoelaces get tied together. They get winded. They're not able to go back outside the cell so that they can repeat that process. And so the cell, which it needs to do, it needs that sodium to perform its action, to perform its duties, it then becomes much less efficient. And so the whole host of cells around it become less efficient at performing their duties. So I want you to think of this like, imagine you're at a stadium watching a soccer game, and you look across the stadium and you see the wave start to roll around the stadium. You see people standing up, waving their arms one by one by one by one next to each other, and it's going around really smoothly and beautifully, and it reaches you, and you do the same thing, and it's fun. It's wonderful. That's under normal circumstances. Now, let's compare this to hyperkalemia, all right? And we'll say you're in that same stadium, but 2/3 of the people are just gone, all right? It's went into triple overtime, and it is 1:30 in the morning, and you got to take the kids to school, and you got work tomorrow, and you're going to get like 3 hours of sleep, and everyone is pretty much vacated, all right? But say someone starts to try that wave again, it's not going to look the same, is it? We've all seen, someone start to do the wave, and it looks kind of, you're like, oh no, that's sad. It doesn't quite work, all right? It's very slow, kind of clanky. I mean, it kind of comes around, but most of the people are doing it kind of out of pity for the person who did it next to them. It doesn't really look very good, all right? Very slow and conductive, all right? Now, that's kind of how things work when your hyperkalemia patient is hooked up to an ECG, all right? Conduction is very slow and clunky, and let's talk about some of those abnormalities, all right? So the first thing that you're going to begin to see is a consistently peaked T wave. Pardon me. And just a reminder here, this right here is that T wave, all right? And that represents repolarization of the ventricles, all right? I did not come up with this imagery, but if you were to think of a fishing pole with a hook right at the top of that T wave, just lifting straight up, it's going to tent it starkly upwards, and that is quite a bit different from these smooth, kind of rounded upwards T waves that we're typically seeing, all right? They look starkly different, all right? That's going to be one of your first things that you're going to see on your ECG. As this patient's condition deteriorates and as potassium continues to accumulate, what you're going to see is a widening QRS. And just a reminder, a wide QRS is defined as a QRS larger than 0.12 seconds or 3 small boxes, all right? And we are measuring that QRS from beginning to end here, all right? And so if this is multiple boxes across, like we just did, we'll say 5 here, all right? That is larger than 0.12, and technically that could be considered wide, all right? Now, typically when we see a wide QRS, that's a ventricular tachycardic rhythm, all right? This is not VTach, all right? Now, this patient can deteriorate into ventricular rhythms, but we're usually going to see a bradycardic ventricular rhythm. So this would be idioventricular in nature and should not be treated with amiodarone, all right? If you're not sure, please contact med control and loop them in on this scenario, all right? So far we have peaked T waves, and we have a widening QRS. That thing is getting wider and wider and wider, all right? As that QRS continues to widen and deteriorate, it is going to start to look like what's called a sine wave, all right? And as it widens, it's going to become so wide that it will kind of morph in to the T wave, and they will become one kind of uniform, analog, large, dominating wave. All right, this is very dangerous, and again, is a lot of the times associated with bradycardia. All right, as that rhythm deteriorates, it can dominate or eliminate the P wave. If you do have a P wave, you might see a prolonged PRI. And just a reminder, that's called a first degree heart block, all right? So, and we are measuring PRI from the beginning of that P wave right before to the beginning of our QRS complex, all right? And that would be anything longer than 0.2 seconds or 5 small boxes, all right? Now you can see prolonged PRIs for a variety of reasons, but this is just one of those scenarios that you might see that, all right? And again, this is a bradycardic patient. So let's look at some examples of this, all right? Now we're looking at 3 different ECG tracings. These are not the same patient. These are different cases I found online here. This is a good example of the beginning of that hyperkalemia where you're starting to see a peaked T wave. I mean, our QRS is, not wide, but those T waves, it really does look like someone is just grabbing it and pinching it upwards, all right? That is acutely large and tall, all right? As this rhythm starts to deteriorate, it may slow down some, and look how this QRS is now substantially wider. Again, this is not the same patient, but I thought that these 3 ECG tracings flowed fairly well together. Now look how wide that is. I would be measuring it probably here. So we're at 1.5, 2.5, 3.5, about 4.5 boxes. That's wide, all right? And it's consistently wide, all right? And then we have also large peaked T waves, all right? And this is kind of flirting with the sine wave. I wouldn't say it's not there, but, this is not smooth by any means, but these borders are getting very close to one another, all right? And so let's go ahead and look. Oh, and another thing on this. You have no consistent P waves. I mean, you might have one here, and if that is a P wave, you definitely have a prolonged PRI, but I don't see anything that I feel confident to say is a P wave. So again, all these things we talked about, we're seeing right here. And here is what that sine wave is going to look like, where that QRS is kind of just flowing right into that T wave, all right? And look how slow and bradycardic and wide this is. This is clearly, it looks ventricular in nature, but it is not VTAC, and it should be treated very differently, just a reminder of that. So how are we going to treat these people? Well, first, let's make sure that we have, 1, clinical suspicion. It has to match what's going on. I'm not necessarily just treating the patient because of their ECG findings. That's extremely significant, but it has to kind of match contextually. Is this patient in DKA? Have they missed dialysis? Have they experienced a crush injury or rhabdomyolysis? Or, what is going on contextually with the patient? And then pair it with those ECG abnormalities. Now, this can be treated a variety of different ways depending on who you are and where you are and your medical director. Locally, what we're doing is 1 gram of calcium IV, IO, and this is going to aim to stabilize cardiac membrane and help prevent life-threatening dysrhythmias, as well as some sodium bicarb, 50 milliequivalents. And this is going to aim to buffer pH and move towards homeostasis. Now, not all of these patients are going to be acidotic necessarily, but there's a high index of suspicion that your patient might be experiencing acidosis that could be contributing to this, and so that'd be why sodium bicarb is given. So let's go over one more time just these causes, all right? Let's just kind of double back and talk about these, and then I think we'll be good here. So we have our missed dialysis patient, all right? This is the most common one. So the kidneys are going to excrete excess amounts of potassium, and so if they are not doing their job and you're not artificially having that done for you, potassium will accumulate and your patient can experience this. DKA is going to be a little different. In DKA, there's a few things going on that are contributing to this. First of all, insulin, which they are in short of, helps maintain potassium inside of that cell. And so a lack of insulin is going to have the opposite effect, where potassium might be creeping outside the cell. Additionally, these patients may be experiencing fluid shifts outside of the cell, all right? And fluid exiting that cell, a lot of times potassium will come with it, and so the potassium will reside outside of that space, all right? Additionally, they may be experiencing acidosis, again, diabetic ketoacidosis, and your body uses potassium as kind of a buffer to deal with this excess of hydrogen ions that your acidosis may be presenting them with. In a roundabout way, there's an exchange happening here between hydrogen ions and the outside, or hydrogen ions and the potassium ions, and your body is kind of exchanging them to try to neutralize that pH. Crush injuries, burns, and rhabdo are all going to have similar pathophysiology where you are experiencing the destruction of tissue. And so I have potassium, large amounts of potassium that is just being emptied into the extracellular space, and it will become circulating in that space and can then impact your patient that way. That's hyperkalemia. Thank you very much for your time. If you guys have any questions or comments, please reach out. Thank you.